Hi, my name is Imad Saloom. I'm from Syria, oral maxillofacial surgeon, doing in my private practice at Saloom Dental Clinic. My topic today will be about placing implants in the anterior mandible and how to play it safe. The anterior mandible had been advocated as the site of choice for implant placement. It has the best bone quality, even in atrophied mandibles. It has the highest success rate of implants, and it's suitable for placing implants and the prosthetic work for all kinds of prosthetic work, full and partial edentulosum. It has an easy surgical access, and it's far away from most important and vital anatomic structures. That's why the anterior mandible is generally considered a rather safe surgical area and ideal site for implant placement. However, during the past decade, several cases have been encountered realizing a near fatal airway obstruction, a serious, very serious complication that could happen after placing implants in the anterior mandible. Those papers were talking about a severe hemorrhage and a severe edema in the sublingual space that leads to a swollen tongue, airway obstruction, and a near fatal, or sometimes, which is rare, a fatal condition. Timothy Saxon, who was chief resident at the University of Minnesota, reported the case in 2004, published in the Journal of American Dental Association. He was talking about a sublingual hematoma, and the swelling appeared to have crossed the midline with a rapid progressing elevation of the floor of the mouth. Al-Bustani and his co-workers reported sublingual hematoma formation after implant placement, and they reported that even this is an uncommon complication, but it is potentially life-threatening, especially in cases of atrophy and increased length of dental implants. Manzikos and his co-workers also reported several cases during other dental alveolar procedures. Manzikos reported a similar case during mandibular torus removal, and other cases had been reported during even trachine bone harvesting. Reviewing the literature will show us dozens of reported cases published all around the world in several journals. Those cases had triggered the alarm for enhancing a new review of anatomic variations related to implant dentistry and new assessment of the blood supply to the mental region in placing implants. Bevitz and his co-workers, after dissecting 74 human adult cadavers, in which they found that 60% after lateral neck dissection, they have a large branch of a submental artery perforating the mylohyoid muscle. And in the past, they considered that the anatomy of the lingual part of the floor of the mouth, the sublingual branch, was responsible for this area. But according to all the research now, it's considered that the sublingual artery was found only to be small or missing or insignificant in 53 of the cases, where other variation exists in 60%, in which that the submental branch of the facial artery pierces the mylohyoid muscle to supply this region. That's why it's considered now, according to other studies also, that the submental artery can be considered the main arterial blood supply to the floor of the mouth and the mandibular lingual gingiva. As we can see that the submental artery is more perforating the mylohyoid muscles. According to Bevitz, that the lingual artery and the hypoglossal nerve were more inferior than classically described before. That's why he stressed on that Submental artery can be considered the main arterial blood supply to the floor of the mouth and mandibular lingual gingiva. This finding suggests the need for a refinement of the extraoral ligation procedure. That means, in case of this kind of bleeding, the facial artery should be ligated first, and then, if necessary, the lingual artery may be clamped or tied. Hofschneider from Vienna, with his publication, he dissected 34 dissected cadavers, where he jumped to the same conclusion that the submental artery is perforating the mylohyoid muscle was found in about 41% of the cases at a distance about 31 millimeter posterior to the mental region. Lucas also, at St. George University, and in a publication with the International Journal of Oral Maxillofacial Surgery in 2008, he concluded also the same result, that the branches of the submental artery were found in the territory of lateral incisors in 72% of the cases, and in the canine area 62% of the cases, whereas in the first premolars in 81% of those cases. Mendinger and Abraham Hirschberg also said that most vessels were found superior to the mylohyoid muscle in the canine area at a distance of about 14.5 millimeter away from the median vertical, and the diameter of the dissected vessels varied from half millimeter into 3 millimeter diameter. That means it could be a very big artery. As we can see here, that the submental artery may perforate the mylohyoid muscle and cross to the midline in a very nearby area from the lingual aspect of the mandible. So, now, what is the cause of this kind of bleeding actually in the anterior mandible area? The first cause is the direct sublingual or submental artery injury, which is due to lingual cortex perforation, which could happen during implant placement. According to Steinberg, this is one of the major causes when making the drilling, and more often it may happen during the tapping procedure and while going deep into the preparation side. We may go deep in a way to perforate the lingual cortex, and this may injure the submental artery in this area. It's because the anatomy of the area of the inferior region of the anterior mandible is so, I will go back again. Because the anatomy of the inferior region of the anterior mandible makes it so vulnerable to perforation, especially in cases with atrophy or increased length of dental implants. This injury can be encountered with the lingual griddle perforation, or most likely sometimes with the use of the bone tap. Relatively, even small perforations can lead to large hematomas. Especially in cases where atrophied mandibles, we can find in severely atrophied mandibles a lingual plate depression, which is located on the lingual aspect, that may lead by mistake to a perforation. This perforation may also happen when using excessive implant lengths, more than 15 millimeters, or excessive implants diameters, or drilling in a wrong angulation related to the anatomy. This could happen when we merely follow the prosthetic and aesthetic needs during implant placement without looking in a correct way to the anatomy, when using this wrong inclination according to our prosthetic needs, and when using excessive implant lengths, we are most susceptible to do this kind of perforation during implant placement, especially when we are dealing with direct implantation after direct extraction. Most of the cases, if we are oriented during the drilling through the root direction, this drilling could sometimes lead to a wrong inclination and wrong drilling and leads to a perforation. As we can see here in the cases, the tooth inclination, if we follow the socket drilling, it may lead definitely to a perforation. As per Evan, this is an example for a severe perforation in the lingual cortex. The second cause is the existence of a mandibular canal, mandibular incisive canal with a true neurovascular supply. This canal, especially in severely resorbed mandibles, we can see sometimes the mental foramen floating over the crest, and there is this small diameter, maybe it's a small diameter canal floating into the anterior region. It's a real canal. The other potential risk in anterior mandible bleeding is the existence of the lingual foramen and all the variation related to it. The lingual foramen is located usually very close to the genio-glossal tubercle. The lingual foramen also may take several shapes and diameters very close to the tubercle of the genio-glossal glossus tubercle. Other variations and other shapes, as we can see here, and the lateral parts also of the lingual part of the mandible. It could be shown here surrounding the area of the genio-glossus tubercle. In CT scans, we can see a small canal perforating the mandible very clear, and in the cone beam scans, this is seen more clearly, very clearly, as a small canal in the area. Baldoni and his co-workers in their study on 100 skull Caucasian mandibles and 100 computed tomographies, they jumped into a conclusion that one lingual vascular canal was found in up to 60% of the patients. This will lead us to the conclusion that a CT scan examination should be routinely performed before any surgical approach to the interforaminal region. This is the recommendation of the research. This is a case showing before doing the CT scan, which was not available at that time. This is a case with the severely atrophied mandible. After doing everything correct, all the dissection done, placing 4 implants in the anterior mandible, as we can see here in the X-ray, which led to somehow a severe hematoma after 24 hours. Of course, this is not a serious case, but this is an indication of what could happen. The other cause, according to Van Stamberg, is the damage to the muscles and other soft tissues, even without direct arterial injury, and this could cause sometimes to brisk bleeding. Timothy Isaacson, with his study, when he published the first case, they didn't find any real cause of the bleeding, and they said at that time that it may be caused by a reflex vasodilation or a rebound vasodilation after the effect of the vasoconstriction of the local anesthetic that time. And this was published in the Journal of the American Dental Association in 2004. All of those studies, and even Van Stamberger, concluded that we have to pay a particular attention to the anatomic peculiarities of this region to avoid any neurovascular complications or injury in this area. Even though this kind of complication is extremely rare, but it's extremely serious to be mentioned. In case if it happens, we should be aware what to do. The thumb rule is do not waste the critical time, because any attempt to ligate or to drain through the lingual flap definitely will increase the amount of bleeding and lead to a worse situation. Do not waste the critical time. Then, what to do? We have to be oriented that the bleeding itself is not the risky issue. The risky issue and the complication is the airway obstruction. That's why we have to focus on preventing the airway obstruction to be happening. What to do in case of suspicion? Apply continuous pressure on the suspected area by placing the thumb inside the mouth over a stack of gauze and the index finger outside the mouth, and to compress the bleeding area until the medical assistants come. Second step to do is inserting a laryngeal airway. This would prevent the tongue to be put in an upward position and close the oropharynx, and to maintain the airway even with severe edema, maintaining the airway through the airway hole. With experienced people or experienced dentists, they can do the laryngoscopy when indicated with either an endotracheal tube or a nasoendotracheal intubation, but this should be done in very experienced hands or in the special course for IV sedation, or they are aware what they are doing in those cases. And if the above attempts fail to secure the airway, the clinician should perform an emergency cricothyrotomy, and this has to be done also with experienced hands. Not every dentist can do it. What everybody can do is to transfer the patient to the nearest hospital and seek an oral maxillofacial surgeon consultation. Well, because sublingual bleeding could be a delayed complication, we have to follow any patient with significant penetrating trauma to the floor of the mouth, and the patient should be admitted to the hospital for a close observation for a minimum of 24 hours under the supervision of an oral maxillofacial surgeon. Preventing this complication comes from surgical precautions that we can take to avoid this kind of complication. Starts with thorough clinical exam, that means visual and finger palpation of the lingual aspect of the mandible. This is mandatory. The palpation and the visualization of the lingual surface to determine any lingual depressions or anomalies, to evaluate any possibility, especially in the area of the depressions, to determine and evaluate any possibility for a perforation potential. Cephalometric X-rays, of course, it has a good aid in determining the inclination of the mandible, especially when we are doing direct implantation. But still, using cone beam scan gives us now, the practitioner, a full idea about the anatomy, the size, and the inclination and the shape of the mandible, so we can prevent totally this complication, and we can detect even small arterial canals that may infiltrate into the lingual aspect of the mandible. This is a case with the sagittal plane As we can see, the arterial canal goes inside the mandible. There are some steps or procedures for prevention during the surgery. We take it as a precautions. The first thing is we should use a direct clear vision. That means a lingual subperiosteal flap is mandatory to ensure direct observation and protection of the mandible structures. We should not hesitate to make our surgical field wide and clear enough to see everything. Using direct and clear vision, a total dissection of the periosteal flap will ensure a good protection of the lingual tissues. Even for small or limited numbers of implants, we should use always clear vision from the lingual aspect as well as the labial aspect. Even cases for 2 implants, we should use direct vision from the lingual aspect and to protect our lingual part of the mandible from perforating. Even for a single implant, it's recommended to make a full thickness dissection of the lingual part and protect our flap, protect the lingual aspect of the anterior mandible. As we can see here, total exposure of the area will lead to good vision and a very good protection, so keep us on the safe side. After doing the initial drilling, we should probe and explore for any small perforations on the site after each drilling. One of the recommendations is to try to avoid the midline where the lingual foramen exists in most of the times. Placing the implants away from the midline may avoid this kind of complication. As we can see here in this case, we place the implants away from the midline. Very important thing is do not use the extraction sockets as our drilling directional guide, because this may lead to a wrong drilling angulation and the perforation of the lingual cortex. As we see the same case here on the CT scans, if we take the inclination of those teeth, if we go on drilling, it will definitely may lead to the perforation of the lingual cortex. That's why even in direct implantation, we should make a full flap with the full dissection of the lingual part to avoid this kind of complication and to not follow the angulation of the tooth. We should follow the angulation of the anatomy by means of using direct, clear surgical access with the lingual subperiosteal flap. As I mentioned, even in cases with direct implantation, the direct implantation may lead us to a wrong inclination. That's why we have to do a full flap that may expose the lingual aspect. So while drilling and placing our implants, we are able to see everything and explore the anatomy in a very correct and accurate way. This is after planning. One of the precautions is we should use gentle drill pressure with great tactile attention. We should not press the lingual tissues with the other finger, and this is a mistake. Sometimes the dentists do it. They just put some pressure on the lingual aspect of the mandible. This may force the artery against the bone, and if a perforation happens, this will lead to the injury to the artery. That's why do not perforate the lingual cortex of the mandible by means of using gentle pressure without the pressing of the tissues in the lingual aspect. As a general rule, Extra long implants with the length of 15 or 18 millimeters has no advantage over shorter ones. That's why using 13 millimeter or shorter implants may reduce the chance of bone perforation, especially that the research said that this artery is in the mean value of distance between the crest is about 13 to 14 millimeters. Using the drill stoppers, or what some manufacturer called a safety or a security kit, as their name shows, they provide real accurate and secure depth drilling free of human error, either visual, and it would prevent from slipping the drill into the lingual cortex and going more than the depth which is planned. In narrow ridges, the chance of perforation is higher with regular or wide implants. That's why using the narrow, new manufactured implants with a diameter of 3 millimeter in cases of narrow ridges would be so beneficial. Even using a tapered-shaped narrow implants with an apical diameter of a 2.5 millimeter approximately will give us more access to the narrow areas and prevent from perforating. This is a great benefit. Now we can use those 3 millimeter implants in this region. Modern technologies have given us the advantage of planning in a very accurate way. We should take all the advantage of those technology in planning our cases. The cone beam scanning is essential for implant placement in the anterior mandible, and even the computer-guided planning with using or without using the surgical guides, but everybody now would recommend using the surgical guides for complicated cases by means of using any software for computer-guided implant study and surgery. This would give us a real ultimate safe and secure drilling, even in cases when we use flapless surgery, and I would recommend that this is the only option to use flapless surgery is when we have surgical guides and surgical and digital planning by means of using the computer-guided surgery, where we can plan exactly and accurately our implants, the angulation, the length, and it's very clear that we can see all the surgical anatomy, all the depressants, all the variations. Using this technology will give us definitely accurate and safe practice. Harvesting bone in anterior region by means of using trephines has same risk and may go deep into the bone and may injure the vessels. Using those trephines should be used carefully and in experienced hands. Even using the microsoles, which has a stopper, it only goes 2.5 to 3 millimeter inside the bone. This is a very nice tool that has a protector, would prevent us from going inside the bone for more than 3 millimeter. Still, it has some risk. Piezosurgery, it's a more safe tool for bone harvesting without injuring the soft tissue surrounding the area of the donor side. My take-home message: this complication is extremely rare, but extremely serious enough to be mentioned and focused on. Still, the anterior mandible is considered as the ideal, easy and safe area for implant placement, and this is the best starting point for the new implantologists. But we have to pay particular attention to the anatomic peculiarities of the anterior mandible, and if we do this, we will be able to avoid this serious neurovascular complication. With this natural smile from the sky, I would like to say thank you for listening to my presentation. Bye-bye.